Welcome back. Have you ever wondered what's really happening on a microscopic level when your skin breaks out, gets scaly, or suddenly forms a blister? Well, today we're going on a pretty fascinating journey into dermopathology. Consider this explainer your ultimate detective's guide to the skin. We're going to look right past the surface to decode the microscopic clues our bodies leave behind.
Think about it. Our skin is our largest organ, right? It's constantly exposed to this wildly complex environment of microbes and elements. Because it's so active, when things go wrong, the skin actually reveals its structural failures through incredibly distinct visual clues. So we're going to scale all the way from the macroscopic stuff you might see in the mirror, all the way down to the tiny, microscopic battles happening at the cellular level.
Here is our roadmap for the explainer today. We'll start with normal skin and basic lesions, move into acute and then chronic inflammatory dermatosis. After that, we'll hit infectious skin diseases, and finally, we'll wrap up with bullous and blistering diseases.
Okay, let's dive right into Section 1, normal skin and basic lesions. We really can't spot the crime scene if we don't know what the neighborhood usually looks like.
Take a look at the normal histologic architecture of our skin. It basically relies on three main layers. Up at the top, you've got the epidermis. That's anchored by basal stem cells and melanocytes and topped off by the stratum corneum, which is this tough acellular layer of keratin. Just beneath that sits the papillary dermis. Now, this area is highly vascularized, which makes it the exact spot where most inflammatory reactions tend to flare up. And then, deeper down is the reticular dermis, housing your larger blood vessels, sweat glands, and hair follicles.
Now, as dermatopathology detectives, we have to look at the evidence from two completely different perspectives. First, there's the macroscopic view, the stuff you can see with the naked eye. For instance, flat discolorations are called macules if they're under 5 millimeters, or patches if they're larger. Raised bumps are papules if they're small, or plaques if they merge into larger elevated areas. But then we have the microscopic view. These are the specific cellular changes we see under a microscope that explain exactly why that bump or patch formed in the first place.
To actually read the microscope, we need the right vocabulary. So let's lock in a few vital terms. Hyperkeratosis is just a thickening of the horny layer. Parakeratosis is when nuclei abnormally stick around in that upper horny layer. But pay close attention to these next two. Acanthosis is epidermal hyperplasia, meaning the epidermis actually thickens with these finger-like projections dipping downward. And spongiosis is fluid edema, basically swelling between the cells of the epidermis. Keep those two in mind because they are absolutely vital clues we'll be tracking down shortly.
Moving right along to Section 2, acute inflammatory dermatosis. Let's look at some fast-acting conditions.
First up is acute eczematous dermatitis. This can be triggered by internal factors, like atopic dermatitis, or even external allergic reactions. Now, remember that word spongiosis from a minute ago? Well, look here. You can see a massive accumulation of fluid between the epidermal cells. When this spongiosis gets excessive, the fluid literally pushes the cells apart, and that's what creates visible vesicles or blisters right on the skin's surface. It is a textbook example of microscopic edema causing a very macroscopic problem.
Next, let's see how things build in a different acute reaction called erythema multiforme. This is often a hypersensitivity reaction to infections or certain drugs. The absolute hallmark clinical sign here are these really fascinating targetoid or target-like lesions. They have a dark, sometimes dead center surrounded by a bright red ring. Microscopically, what's going on is that lymphocytes are actively attacking the cells of the basal layer. This damage causes the premature death of the cells, a process called dyskeratosis, which leads directly to that dark central necrosis you see in the target lesion. But what happens when that fast-acting inflammatory battle doesn't actually end? That brings us to Section 3, chronic inflammatory dermatosis. What's truly fascinating here is how a condition like psoriasis behaves. It's an immunological disease driven by sensitized CD4+ T cells. Clinically, you'd see pink plaques covered in this very distinct silvery white scale. But look through the microscope and the true story unfolds. You see a complete loss of the granular layer, thick parakeratotic scales where the cells are holding onto their nuclei, and these little pockets called Monroe microabscesses. Notice those prominent dilated blood vessels in the dermal papillae? Because they sit so incredibly close to the surface, if a patient simply scratches off one of those silvery scales, the vessels instantly bleed. That's a classic clinical clue we call auspicious sign.
Now let's contrast two different chronic conditions. On one side, we have lichen planus. This is driven by CD8+ T cells directly attacking the basal layer. That intense localized battle makes the dermoepidermal junction take on this jagged, sawtooth appearance. Clinically, it shows up as purple papules with these fine, white lace-like lines called Wickham stria. On the other side, contrast that with lichen simplex chronicus. This actually isn't an autoimmune attack at all. It's simply the skin's mechanical defense against repeated rubbing and scratching. The skin responds by forming a distinct, thickened, psoriaceform acanthosis, which just makes the area tough and leathery.
All right, let's pivot. We've looked at the body fighting itself. Now Section 4, infectious skin diseases, where foreign invaders break through the barrier.
We can broadly categorize these external pathogens into three main groups. You have bacterial infections, like Staphylococcus aureus, which cause superficial yellow sores known as impetigo. Then you have fungal infections, which absolutely love to thrive in the stratum corneum. A classic example is Malassezia furfur, the culprit behind Tinea versicolor. Under a microscope, it has a highly distinct look that pathologists literally call meatball and spaghetti. In fact, pathologists often have to use special PAS and silver stains just to make these fungal organisms pop so they can see them. And finally, we have our viral invaders, most notably HPV, which causes warts.
Take warts, or verrucae, for example. These are essentially proliferative lesions caused by the human papillomavirus. The virus actually hijacks the skin cells using its E6 and E7 oncoproteins, driving completely unregulated growth and artificially extending the cell's survival. That's what creates that rough, pebble-like surface. But the absolute smoking gun for an HPV infection under the microscope is the koilocyte. This is a large cell with a bright cytoplasm and a really distinct, crinkled, raisin-like nucleus. When a pathologist spots that raisin nucleus, there is no doubt HPV has been at the scene.
We now enter our final chapter, Section 5, bullous and blistering diseases. These are severe conditions where the immune system destroys its own structural integrity.
So the crucial point here is this. When a blister forms, the exact anatomical level where the skin splits dictates the diagnosis. Think of the skin exactly like a multi-story building. If the roof blows off just under the very top layer, it's a subcorneal blister. If the floor collapses right above the basement, it's a suprabasal blister. And if the entire foundation separates from the ground below, well, that's a subepidermal blister. Let's compare two of the big ones. In pemphigus vulgaris, IgG autoantibodies attack the desmosomes, which is basically the glue holding the epidermal cells together. This causes the cells to just fall apart, a process known as acantholysis, creating a very fragile blister right above the basal layer. In contrast, bullous pemphigoid attacks the hemidesmosomes, the actual anchors holding the entire epidermis to the dermis underneath. Because the whole epidermis lifts off intact without that acantholysis, the resulting subepidermal blister is much harder, tighter, and way less likely to rupture.
And these microscopic differences translate into very different and often very painful clinical realities. Because pemphigus vulgaris blisters are suprabasal and lack a thick roof, they tear incredibly easily. This leaves deep, extensive erosions that are highly prone to secondary infections. Conversely, pemphigus foliaceus forms a much more superficial, subcorneal blister, which usually results in a milder clinical presentation.
And this right here brilliantly illustrates how we definitively solve the case. What you are looking at is direct immunofluorescence, which is the gold standard diagnostic tool. By using special glowing markers, pathologists can literally see the autoantibodies caught in the act. In pemphigus, the IgG antibodies deposit along the cell membranes in this striking, bright green fishnet pattern. It's an undeniably beautiful image of a highly destructive process, showing exactly where those intercellular connections are being targeted.
From the completely normal layering of cells to the chaotic battlegrounds of autoimmune disease, our skin is just so much more than a simple wrapper. It's a highly dynamic, complex organ that's constantly adapting, defending, and yes, occasionally attacking itself. I really hope the structured journey through dermatopathology has given you a profound new appreciation for the vast, unseen cellular defenses operating on your surface every single second of the day. Thanks so much for focusing in with me today on this explainer. Keep asking questions and keep exploring the fascinating microscopic world around you.